Infective endocarditis, an overview by Dr. Amr Gawaly, Assistant Professor of Internal Medicine. Introduction. Infective endocarditis is due to microbial infection of the heart valve, naive, naive, or processed. First of all, we must know that the infection in the heart is a horrible disease. It is not a simple disease. So, mostly all the normal valves not affected by this disease, and the valve mostly is a diseased valve or processed valve, like or a congenital anomaly like septal defect. The term infective endocarditis is better than bacterial endocarditis because we have many organisms can be affect the heart, included the bacteria and the fungi and so on. Virulent organisms may infect normal valve, especially when the patient is generally depleted or immunologically incompetent. But usually we don't see many patients with this problem. Mostly if the patient is normal valve with no congenital anomalies or any other problem, the organism will not affect the valve except if it is a virulent organism. In etiology, underlying cardiac lesion. This is very important. Abnormal jet or of the blood or turbulence of the blood. If the bacteria is flowing in the blood and is transmitted from side to side, when it is go to the heart, if I have abnormal jet or turbulence, mean that they have a mitral stenosis, mitral regurgitation, and so on, so the blood go in different direction rather than the normal direction, or it going from the weak from stenosed or narrow valve. It is very easy to making the bacteria to attach to this valve. This occur in the congenital disease like VSD, ventricular septal defect, and PDA, patent ductus arteriosus. Rheumatic mitral valve disease and aortic valve disease. The second problem in the valve is the prosthetic valve. The third problem is the bacteremia. So you must have a cardiac lesion or prosthetic valve and the bacteremia. How that how the bacteria is introduced and to the heart and making this problem. First one is endoscopy or catheter, minor or major surgery, especially cardiac surgery, tooth extraction and chewing candy, IV cannula or cardiac catheter, tooth brushing, it is a daily activity. All these resources may making all these resources may make uh, the bacteria to go inside the heart and making this horrible disease. Types of bacteria is Streptococcal viridans, Streptococcus faecalis, and this is mostly present in the GIT, Staphylococci and pneumococci, and the fungi like Candida or Aspergillus. Pathogenesis. Infections tend to occur at site of endothelial damage because this is a deposit of the platelet and fibrin in this area. Okay, so the area of endothelial damage is rough surface, and this is very important. Rough surface, not a smooth surface. So the colonization of the bacteria or this area is very common and very easy. The avascular valve tissue and the presence of fibrin help to protect the proliferation of organisms from host defense mechanisms. Again, if the valve is inflamed or the valve is fibrosed, uh, uh, help to protect the proliferating organism from host defense mechanism. This is the normal problem in the normal structure of the valve. It is fibrin deposit, but in the inflammation or presence of edematous valve, it is making the site is easily to be infected by the bacteria. When the infection is established, vegetation, very important term, vegetation. It is composed of organisms, fibrin and platelet, grow and may become large enough to cause obstruction, and they may break into septic emboli. So endocarditis is more common in the left side, mitral valve disease and aortic valve disease. Why? Because the pressure in the left side is very high than the pressure in the left side. So it can taking the bacteria and attach them to the valve and making what's called vegetation, and the vegetation is spread to other side. Clinical picture. You know that any infection, you will have a fever, headache, malaise, and anorexia, and so on. But this in the severe form, it is called the toxic manifestation. It's called toxic manifestation. And this severe form occur because the microorganism is in the heart. Okay. Also, original cardiac lesion is present. Also, new murmur. This is maybe developed, and this is very characteristic sign for the infective endocarditis. Because if the murmur is not developed, if the new murmur is developed, it means that I have an active lesions now and have a problem now. So this is a very characteristic for infective endocarditis. Thromboembolism means that this vegetation can be detached from the valve and going to any site in the brain and so on, making what's called thromboembolism. CNS or cerebral stroke, cerebral infarction can occur due to vegetation or thromboembolism. Upper and lower limb ischemia, this occur due to thrombosis in the upper and the lower limb arteries. Mesenteric occlusion, this is lead to acute abdomen, and acute mesenteric occlusion leading to what's called acute abdomen, and the acute abdomen uh, uh, also due to thrombosis, which will obstruct the arterial system of the GIT. Renal. If the renal artery is obstructed or one of his branches by thrombi, it will make cross hematuria. Immune complex. Immune complex means we have a membranoproliferative or membranoproliferative infection in the kidney, making microscopic hematuria and proteinuria. Flea-bitten kidney due to capillaritis, inflammation of the capillaries in the kidney, making small dots, red dots, like the flea-bitten. So it's called flea-bitten kidney. In the eye, we have rough spots in the fundus examination. It is a vasculitis. Subconjunctival hemorrhage is a vasculitis. Sudden blindness if the central retinal artery occlusion. You see that the clinical picture of this disease is very dangerous and very horrible, and it is a very difficult. So early treatment and management for this patient is very important. Upper limb, ocular nodules, it is a vasculitis, small nodules over the bulb of the finger, and it is usually tender. Clubbing, we have a pale clubbing or toxic clubbing. Pale clubbing, this is occur due to hypoxia, if we have a heart affection, and the toxic clubbing, this is occur due to infection or bacteria. It's occur with long-standing cases. Splinter hemorrhage, the longitudinal undernail hemorrhage, it is also due to vasculitis. Spleen, it occur in the long-standing case splenomegaly, soft mild enlargement, sometimes tender. Fraction rib usually present with splenic infarction. When the spleen is enlarged, it means a fraction with the capsule of the spleen with each other, making this. The first item is that we have inflammation and manifestation of fever and headache and malaise, and the second one is the vasculitis, and it making hemorrhage and sometimes infarction, and the last one one is the infection itself and its complication. As you see, it is a horrible disease, and so if you left the patient without the treatment, once you suspect that it is an infective endocarditis, it will be very, very difficult to manage the patient after that. So, what is the investigation we can done to diagnose this patient? The investigation is blood culture, and it is a crucial investigation. Three samples for aerobe and special culture may be necessary. Echo for vegetation, small size vegetation, few millimeter can be seen by transesophageal echo. Transesophageal echo as a procedure using by upper endoscopy to introduce an ultrasound probe to see the heart transesophageal. ESR is very high, total X-ray count is very high, CRP, CBC show normochromic normocytic anemia. Sometimes when we are doing urine analysis, we can find the proteinuria and hematuria. The treatment for this patient, once you suspect, give empirical antibiotic. Very important. Don't wait for the complication. Gram positive and gram negative. For gram positive, we giving penicillin G 25 million unit IV per day or vancomycin IV every 12 hours. For gram negative, gentamicin 80 milligram per 12 hour IM or third generation cephalosporins 2 to 4 IV per gram per deciliter per day. When the culture is available, give antibiotic according to the culture. For 6 weeks, Streptococcus viridans, penicillin, gentamicin, Streptococcus picus, gentamicin, and penicillin. Surgery indication, replacement of the infective prosthetic valve, abscess formation, large vegetation of septi. So the surgery is not is not an important treatment for this patient except in certain situations. Again, the procedure, we giving a prophylaxis antibiotic before the procedure because this procedure may be introduce the bacteria inside the heart. Dental or upper respiratory tract procedure under local anesthesia. If we give amoxicillin 3 gram orally 1 hour before. If allergy to or received penicillin in the last month, clindamycin 600 milligram orally 1 hour before. Dental or upper respiratory tract procedure and general anesthesia, amoxicillin 1 gram IV at induction plus amoxicillin 0.5 gram orally 6 hours later. If allergy to or received penicillin in the last months, vancomycin 1 gram IV infusion over at least 100 minutes plus gentamicin 120 milligram IV at induction. Special risk patient, prosthetic valve or previous endocarditis genitourinary procedure giving amoxicillin 1 gram IV plus gentamicin 120 milligram IV induction plus amoxicillin 0.5 gram orally 6 hours later. If allergic to or received penicillin in the last month, vancomycin 1 gram IV infusion over at least 100 minutes plus gentamicin 120 milligram IV at induction. Obstetric and gynecology procedure or gastrointestinal surgery instrument as for special risk patient only. We have what's called DUCS criteria for diagnosis of infective enteritis. As we see, the infective enteritis is a horrible disease, and we must not stay without intervention till the investigation is done. Okay, major criteria: positive blood culture, expected microorganism for infective endocarditis from two separate blood culture, evidence of endocardial involvement by echo or installation intracardiac mass or abscess, new valve regeneration. This is a major criteria. And the minor criteria favor more than 38 centigrade, immunological phenomena, rotospots, oslar nodule, glomerulonephritis, predisposition to infective endocarditis, heart condition or IV drug abuse, vascular phenomena, arterial embolic, conjunctival hemorrhage, and so on. Echo finding consistent with infective endocarditis, but major criteria are stated above are not met. Microbiological evidence of effective endocarditis. Blood culture are positive, but major criteria are not met as previously described, or serological studies support an infection consistent with diagnosis of infective endocarditis. So you must at least have one major criteria, two minor, or two major criteria and one minor for diagnosis.